Oh, great, great, great. I think then we can start with the proceedings. And with that, I would like to welcome you all for today's 13th series on the icon Amrita E-Gurukul. And we've had some brilliant lectures before from wonderful speakers. And, the series has been a major hit with the residents, especially the people who've passed the DNB exams recently, and also the DM candidates. So without any further ado, I would like to introduce to you our program director for today, Dr. Vidit Kapoor. He's an assistant professor medical oncology at Amrita Institute of Medical Sciences, Faridabad. Over to you, sir.
Thank you, Dr. Karan, and good afternoon, everyone. It is my pleasure to welcome you all once again, and this time for the 13th session in the continuing E-Gurukul series that we all know is an online educational initiative that provides high quality learning for not just for students and fellows, but also for practicing medical oncologists. And I'm sure, like Dr. Karan said, that we have learned a lot through this forum together, and it continues to offer more and more with each session. So today's session will focus on newer drugs in solid tumor oncology, where we will explore some of the most promising and recently approved agents, including antibody drug conjugates, small molecules, tyrosine kinase inhibitors, immunotherapies, and we will study about novel mechanisms of actions, emerging treatment paradigms across various cancer subtypes. And to guide us through this important discussion, we are honored to have with us our very own Dr. Saphalta, who I have personally known as a friend, as a colleague, and a highly compassionate medical oncologist. She is currently associate professor and senior consultant in the Department of Medical Oncology and Hematology at Amrita Hospital, Faridabad. So without waiting any longer, I would like to invite Dr. Saphalta to take stage and moderate the session. Thank you so much.
Hi, good afternoon to everyone, and thank you, Dr. Vidit. He is my teammate and a very friendly guy, and I love to work with him. So, our mentor of the session will be Dr. Hemanth, and he is one of the very learned medical oncologists of India, and he is consultant medical oncology from Mangalore Institute of Oncology. Then, our speaker is Dr. Akhil Santhosh, and he is from AIMS, and he is one of the gems from AIMS. And in the medical oncology group of AIMS, he daily posts new articles, and in fact, I look forward for those articles, and it's like my those articles I read when I am on the way to my hospital on the workplace, and those are the things which I get updated daily in the morning, and in the evening also the same thing. And he is one of the medical oncologists from AIMS who has highest NEGM publications, especially the letter to editor, and he's a very very learned person. Then our examiner, all know about Dr. Amol Akhade. He has been internationally known about his critical claims, critics on the multiple articles which are published, and he has very strong view for many of the things which we all agree many times. Then we have our examinee. They are Dr. Yash Rakesh Shah, who is third year resident, DM Medical Oncology, student from TMH Mumbai, and Dr. Raghuram Mahishi, who is third year DRNB Medical Oncology student from TMC Kolkata. Welcome you all. Over to you, Dr. Akhil.
Can I share my slides, Karan, if that's okay?
Sure, sir.
Okay. Yeah. Are my slides visible?
Yes, sir.
Okay. Yeah. Good afternoon, everyone. At the outset, I would like to thank the entire Amrita E-Gurukul team and the academic coordinators for inviting me to speak today. And thank you to Saphalta ma'am for those kind words. So today, I'll be discussing about newer drugs in solid tumors. So this presentation will be slightly different compared to the previous lectures that we had. So in the previous lectures, we had more detailed discussions about each and every drug. So those were the conventional, the older the drugs, where every student is actually expected to know in depth about each drug, the dosage, the vial strengths, the mechanism, and how to administer those drugs. So here for solid tumors, the newer drugs in solid tumors, you're not expected to know that much in detail. So I have discussed in such a way that you need just to know about the mechanism of the drug, the indication, the major toxicities, and the settings in which it is approved. That's it. So you don't have to by heart the doses, and you don't have to know how to administer them and what are the vial strengths available. So those are not required with respect to the newer drugs. So without further ado, I'll just get on with my slides. So I have divided it into various sections like GU, GI, head and neck, CNS, thoracic, breast, and a little bit on sarcomas and supportive care. So I'll start off with supportive care. So let's just start with ponsegromab. So ponsegromab, it is a potent, highly selective monoclonal antibody which acts against the growth differentiating factor 15. So this is one of the recent drugs that have been tried in cancer-related cachexia. And so how does it act? So basically it acts by inhibiting the interaction of growth differentiating factor 15 with the GFRAL receptor. So basically, the study, it was published in NEJM a few months back, so where they have explored different dosings of the drug. So basically, it was a 1:1:1:1, a 4-arm phase 2 RCT compared to placebo. So basically, they've explored three different doses: the 100 mg, 200 mg, and the 400 mg. The route of administration, that is subcutaneous. So this is the only anti-cachexia drug which acts through a subcutaneous route, and basically you have to administer it every 4 weeks and for a total of 3 doses. And the most common side effect is nausea and vomiting. So this was a trial that was published 2 months back in NEJM, a phase 2 RCT, smaller population group, and the primary endpoint of the study was the change from baseline in the body weight at 3 months. So what they had seen is that the group difference in the weight gain, it was highest for the 400 mg, around 2.8 kilos compared to 1.92 in the 200 mg arm and 1.22 in the 100 mg arm. And as you can also see that the side effects that I mentioned before, the nausea and the vomiting and the fatigue, that is more common with the 400 mg dosing. Also, a small mention, ponsegromab is not yet FDA approved. And you also need to know that there are no FDA approved drugs currently for cancer cachexia. So all the drugs that we use in our OPDs, your corticosteroids, olanzapine, amoxicillin, and mirtazapine. So all this are not, none of them is FDA approved as of now. So, coming to a slightly older drug, I thought I should mention it because it has got a very important place in our routine clinics. And I'm not sure how many of you guys use dextroxin on a daily basis. So, so what is dextroxin? Dextroxin is an iron chelating agent which is FDA approved for the prevention of doxorubicin-induced cardiotoxicity. So, how does it act? So, basically, the drug, when it is administered, it converts into a ring open form intracellularly, and it interferes with the iron mediated free radical generation. So it has got a mechanism somewhat similar to doxorubicin. Doxorubicin, also you must know that it also causes cardiotoxicity by interfering with the iron mediated free radical generation. So dextroxin competes with doxorubicin in that manner. So two vial strengths are available, 250 mg and 500 mg. So contrary to popular opinion, the drug is not that costly. So 500 mg drug, basically it is not available here. You have to import the drug. So it costs around 25 to 30,000 for a 500 mg injection. So your entire course, if you're planning to give 5 to 6 cycles of doxorubicin, would come to around 1.5 to 2 lakhs. So the entire treatment cost would be less than a single cycle of your immunotherapy drug, like your Pembro or Nevo. So compared to that, it is relatively cheaper. So what is the dose of dextroxin that you should give? So this slide is very, very important, and I recommend all the exam going students to buy heart this. The dosage ratio is 10:1. So whatever mg per meter square doxorubicin you're giving, give 10 times the dose of dextroxin. For 50 mg per meter square, it will be automatically 500 mg per meter square. For 75, it will be 750 mg per meter square. It is never given as a push. So you can give doxorubicin as a push, but not dextroxin. It is administered as an infusion over 15 minutes. And you should always give dextroxin first and doxorubicin later, and not the other way around. So these 3 points you should also be aware of. And dexazoxin, another indication of dexazoxin is also for treatment of doxorubicin-induced extravasation. So, but we do not use it routinely for that purpose. So coming to a few drugs, few drugs in gynae oncology. So many of the other drugs have already been covered in the previous presentation. So I had gone through that. So basically, I'm covering those that have not been covered yet. So let's talk about a newer molecule called cadonilimab. So what is cadonilimab? So basically, it is a bispecific antibody with a crystallizable Fc null design targeting CTLA4 and PDL1. So what is different with respect to cadonilimab when compared to your other routine IO molecules? So basically, this molecule is an Fc null design. So basically, it has got no binding to Fc receptors. Hence, there is minimal antibody dependent cellular cytotoxicity, antibody dependent complement phagocytosis, and your interleukin release. So basically, the toxicity of cadonilimab is lesser compared to your other uh, immune-related adverse events with your conventional IOs. And it has got a specific binding ability, higher binding ability in a high-density PDL1 and CTLA4 compared to a low-density setting. And hence, that is also one of the reasons why it causes lesser side effects. So this was a landmark study that was published recently in Lancet Oncology. So this was a Chinese trial. So where they have compared cadonilimab plus platinum-based chemo with or without bevacizumab as first-line treatment for metastatic CS cervix. So you can see that this combination treatment has got a PFS and an overall survival advantage, around 4 months delta of PFS, and the median OS is not reached. The dose, as I again told you, you don't have to remember all the doses for these newer drugs. It is 10 mg per kg IV every 3 weeks. The most important thing that you need to know is the side effects are lesser. Also, it has got an activity in patients who have lower PDL1 levels and in patients who have not received bevacizumab also. So, if you guys remember that your first line currently approved treatment regimen for a metastatic CS cervix is your Keynote 826 regimen, combining pembro plus platinum-based chemo. And for that, the inclusion criteria was basically PDL1 expressors more than one. So, but in the case of cadonilimab, it acts even in PDL1 less than one. So let's come to the other drug, which is approved as a second-line agent in metastatic cervix, is tisotumab vedotin. So this, I think, you guys must be familiar about this drug. It is again an antibody drug conjugate. Here, basically, it is directed against the tissue factor. So tissue factor is one such receptor that is highly expressed in your metastatic CS cervix patients. And the dose, and again, the payload is your MMAE, and the dose is 2 mg per kg given every 3 weeks. And the most important thing is you need to remember the classical side effects associated with tisotumab. So basically, it is ocular side effects. So all grade ocular side effects amount to around 70 to 80% in tisotumab vedotin, where grade 3 events account for around 10 to 12%. And it also inhibits tissue factors. Hence, bleeding events are also associated with tisotumab. And just like your vedotin payloads, peripheral neuropathy is also an associated side effect. So coming to the trial which is evaluated is tisotumab versus your standard of care. So that is the Innova TV trial, Innova TV 301. Here they have taken around 500 patients. It is a phase 3 trial in second line setting. They've compared tisotumab versus your second line chemo, and it has got a 2 months median overall survival advantage. And the response rates was around 17.8% in tisotumab versus your 5.2% in with your conventional chemos. And again, this is very, very, very important. So if you are administering tisotumab, you need to follow a stringent ocular prophylaxis. So basically, it begins prior to your infusion. So you need to have you need to have a proper ophthalmologic evaluation by an expert ophthalmologist. And on the day of infusion, pre-infusion, you're supposed to administer corticosteroid and vasoconstrictor eye drops. So, and cold packs have to be given during the infusion of tisotumab, which lasts over 30 minutes and 20 minutes post your infusion. And your the steroid eye drops need to be continued for 2 to 3 days post your tisotumab infusion. So, and I also strongly feel that this sort of an ocular prophylaxis regimen can also be employed for your other ADCs which has got keratopathy as a predominant side effect. For example, your mirvetuximab soravtansine or your enfortumab vedotin that is given in bladder. So, but the strongest data is for tisotumab, but I feel this can also be applied to other settings. So coming to mirv soravtansine. So again, this is your if I want to put it in a single line, your only first line drug in metastatic in your platinum resistant CA ovary, which has got a survival advantage. So again, this is approved for your folate receptor alpha expressing platinum resistant CA ovaries. So the one important thing is you need to know the definition of a high FR alpha. So basically, high FR alpha is your more than 75% of your cells with a strong staining, that is more than 2 plus staining, and it is seen in around 35 to 40% of platinum resistant CA ovary. So for your other 60%, you cannot give your mirvetuximab soravtansine. Again, it is the FDA approved first line. So the initial trial that has evaluated mirvetuximab was your Soraya trial. So that was a phase 2 trial. And here they've taken only your FR alpha expressing tumors and around 30% response rates with a duration of response of around 7 months and an OS of around 15 months. So this is one of the first instances where you get an overall survival of more than 1 year in a case of your platinum resistance ovary. And so coming to the most important trial, this was a phase 3 Mirasol trial. Again, they have taken around 450 odd patients, only FR alpha expressing tumors. And here they've seen that the median PFS was around 5.6 months versus around 3.98 months in favor of mirvetuximab. Again, you can see that the OS delta is around 4 months. So this is a huge survival advantage in your platinum resistant setting. Again, the notable side effects, it is easier to remember. Soravtansine payloads, they also have a peripheral neuropathy as a side effect, alopecia, and just as I mentioned before, it can also cause ocular events and keratopathies. So now let's move on to thoracic oncology. So let me discuss about zenocutuzumab. So what is zenocutuzumab? So basically, NRG fusions, they are a very rare class of fusions which are seen in around less than 1% of solid tumors. So you need to remember two important histologies where this NRG fusion is found. One is your invasive mucinous adenocarcinoma of lung and in your KRAS wild pancreatic cancer. So you know that KRAS is seen in around 90 to 95% of pancreatic cancer, and in the rest, and in around 1%, you can see NRG fusions. So how does NRG trigger oncogenesis? NRG1. So basically, your NRG1 it binds to HER3 to an EGF-like binding domain, which triggers the HER2 HER3 heterodimerization, and again, this in turn activates your PI3K, AKT, mTOR pathway, and leads to oncogenesis. So what does zenocutuzumab do? So basically, it is an IgG1 bispecific antibody. It binds against your HER2 and HER3. And the dosing again is 750 mg every 2 weeks. So you must have all read this trial, which was recently published in NEJM. So this was the Energy trial. This was a registration trial of zenocutuzumab. Here, basically, they have taken around 12 different tumor types, but for us clinicians, only 2 tumor types, as I told, are important. One is your mucinous adenocarcinoma lung and your pancreas. So in NSCLC, the response rates were around 29%, and in CA pancreas around 42%. And one beautiful thing about zenocutuzumab is that the patients who derive response, the ones who respond, they maintain this response for a very long time. So the median duration of response is around 1 year for zenocutuzumab. So just imagine in a CA pancreas patient getting those such responses. So this is more than the responses that you get with your FOLFIRINOX or your Gemna-Paclitaxel. But again, this is seen in only less than 1% of 1% of patients. So again, for your patients if once this drug is available. So this is another biomarker that you can check. And again, the most common adverse events, as you all know, once your EGFR is inhibited, it can cause diarrhea along with fatigue and nausea. So again, this was recently FDA approved zenocutuzumab for these two entities, NSCLC and pancreas, in December last year. So coming to Dato-DXd, datopotamab deruxtecan, it is a differentiated TROP2 ADC, and the payload is exatecan, just like your trastuzumab deruxtecan. And just like deruxtecan, it has TDXd, it has also got a cleavable tetrapeptide-based linker. And the dose is 6 mg per kg every 3 weeks. For Dato-DXd, at least you need to know 2 trials, most importantly. One is your Tropion-Lung-01. This was the first trial which had evaluated Dato-DXd versus docetaxel in patients previously treated metastatic NSCLC. So this was a very important trial. And so basically, in the ITT population, in the entire study, so there was no advantage of Dato-DXd versus docetaxel. So this is very important. Only some benefit, and that too a PFS benefit, was seen in your non-squamous histology. So mainly your adeno, and in your adeno and amongst the adenocarcinomas, only in the genomic alteration positive subset, only in your EGFR mutation subset was there a significant PFS benefit. Again, OS there is only numerical improvement in OS. And one important thing is the side effects of your Dato DXD is slightly different compared to TDXD. TDXD, you all know it is your cytopenias, your ILD, hepatotoxicity. But in Dato DXD, the most important is your stomatitis and oral ulcers. ILD rates are very low for datopotamab deruxtecan. So I just want to highlight this trial, Tropion-Lung 04. The final results are not yet published. So here they are trying to bring Dato DXT into the upfront setting, frontline setting, where Dato is combined with IO plus carboplatin in your first line NSCLC. So this is your Tropion-Lung 05. And a word about Tropion-Lung 04. The previous trial was 04, and this trial is Tropion-Lung 05. In 05, what they've done was they have taken out that specific subset from the Tropion-Lung 01 where the benefit was shown. So basically, they have taken only the genomic alteration subset. In this trial, around 55% was EGFR positive and around 25% were ALK positive. And they've shown that in the EGFR positive patients, the response rate was actually good. It was around 43.6% ORR with a duration of response of around 7 months. So again, this is a phase 2 trial. So coming to some other newer molecules in thoracic oncology, so let's talk about patritumab deruxtecan. So what is patritumab deruxtecan? So it is a newer ADC. It targets HER3. So HER3 is expressed in around 75 to 80% of metastatic NSCLC, and just like all your deruxtecans, it has got a top one payload, tetrapeptide based linker, and the dose is 5.6 mg per kg given every 3 weekly. And the side effect profile is slightly different compared to the other ADCs. So here, mainly hematological side effects predominate in patritumab. So this was again evaluated in the HERTHENA-Lung 01 trial. So this was a publication in the Journal of Clinical Oncology last year. This was a phase 2 study. Basically, they have taken EGFR positive patients who have progressed after an EGFR TKI. So basically 200 odd patients. They have tried HER3-DXd. The ORR, again, it is not that great, around 30% responses with a PFS of around 5 months, OS of around 11.9. Mind you, this is a phase 2 data. And so it is just another drug to your entire armamentarium of your post EGFR TKI options that you have. So again, a word about telisotuzumab vedotin. So what is Teliso-V? So Teliso-V is basically a first-in-class c-Met-directed ADC conjugated to MMAE. So here, one important thing that students need to know is here they have not taken MET amplification or MET via sequencing. So this is basically an IHC-driven approach. So basically, they have taken c-Met overexpression via IHC as a biomarker to target the payload. So it was shown that around 40 up to 40% of NSCLC they overexpress c-Met. And the definition was around, again, 75% of tumor cells with membrane staining at any intensity. The dose was around 1.6 mg per kg, Q2 weekly. And again, the luminosity this was the Teliso-V was again assessed in the luminosity trial. In the luminosity trial, basically they have taken previously treated NSCLC who overexpress c-Met. So again, they've shown that the response rates are around 30% with a duration of response of around 8.3 months and a PFS of around 5.7 months. So again, not that impressive. The classical side effects, as you all know, for any vedotin payload is your sensory neuropathy and peripheral edema. Peripheral edema is due to, it is a class effect of your MET inhibition. So coming to ensartinib. So ensartinib is not that new a drug. Basically, this has been around for the past 10 to 12 years. So why I'm presenting is that this drug has recently gotten an FDA approval around 2-3 months back. So ensartinib is your second generation ALK inhibitor, just like your ceritinib and brigatinib. And the initial efficacy, it was established in the EXALT phase 2 study. So this was a 160 patient data where your ensartinib produced response in around 50% of patients. And again, it has got a pretty good intracranial control. Also around 28 out of 40 patients had shown a response, intracranial response. Rash and coming to your adverse events, again, compared to the other side effects are pretty much compared to the other ALK inhibitors, they are the same. Rash, your increased AST and ALT. And this was the landmark phase 3 trial, which compared ensartinib versus crizotinib. So this was published in JAMA Oncology a few years back. So here they've shown that the PFS associated with ensartinib was around 2 years compared to 1 year for crizotinib, with a good intracranial ORR. The final overall survival results are not yet published for the EXALT 3 trial. And on last December 2024, FDA had finally approved ensartinib for ALK-positive NSCLC in the first line setting. So for the exam goings, so currently there are 3 second-generation ALK inhibitors. Your ensartinib, bricatinib, and alectinib. So coming to taletrectinib. So taletrectinib is basically a newer 4th-generation CNS active ROS1 TKI. So the other 4th-generation ROS1 TKI, I hope you all must be knowing, is repotrectinib. So what is special about these newer 4th-generation ROS inhibitors? So basically, they have pretty much selectivity over your TRKB. So there is basically lesser inhibition of TRKB, and this is the reason for its lesser neurological adverse events. So this is very important. And just like your other 4th-generation repotrectinib, the taletrectinib is also active against your predominant resistance mutations like your G2302R, and the recommended phase 2 dosing is 600 mg. The side effects, it's again raised OTPT enzymes, diarrhea, nausea, and vomiting. So taletrectinib, basically, this paper, beautiful paper published recently in JCO, where they have combined the 2 trials, Trust 1 and Trust 2. Basically, taletrectinib, as you all know, is a Chinese molecule. The Trust 1 study was conducted exclusively in Chinese patients, and Trust 2 was pretty much more a global population was included. So basically, this paper, they pooled the results of both these trials, and they've shown that in your TKI naive patients, ROS TKI naive patients, response rates to the tune of 90% were achieved, with a median PFS close to around 4 years. So this is pretty impressive, pretty unimaginable for ROS1 setting, metastatic setting. And in your pre-treated patients, the response rate slightly dips down to around 55%, with a PFS of around 16 months. So where does taletrectinib stand compared to your other ROS1 TKIs? So you can see that, so here I'm comparing 4 drugs, crizo, entrectinib, repotrectinib, and taletrectinib. So you can see that the response rates are only slightly higher with taletrectinib, but your intracranial response and your progression-free survival, they are pretty much, there's a huge gap between taletrectinib and repo compared to your previous generations. And coming to your class side effects, so you can see that drugs like entrectinib and repotrectinib, they have a huge incidence of your CNS side effects, your headache, neurosensory deficits, cognitive impairment, but that is lesser with taletrectinib. So with taletrectinib, it is mainly your diarrhea, edema, and your OTPT dysfunctions. So that's it with taletrectinib. So next, let's come to ivonescimab. So this has created a huge stir in amongst the entire medical oncology fraternity recently. So this was Trump to defeat even the King Keytruda recently, where it has been compared with pembrolizumab. So what is ivonescimab? So ivonescimab is basically your bispecific antibody which targets PD-1 and VEGF. So in my initial slides, I had discussed another bispecific antibody, that was cadonilimab. Cadonilimab was against PD1 and CTLA4. Ivonescimab is against PD1 and VEGF. So again, it's a Chinese drug developed by Akeso Biopharma. And students, you need to learn, you just need to remember 2 settings where ivonescimab has been tried in lung. One is your Harmony 2 trial. Harmony 2 trial, basically, they have compared ivonescimab versus pembro. So here there was no chemo at all. So it is for PDL1 positive NSCLC. So here they've taken patients, chemo naive or treatment naive patients with PDL1 more than 1%. They have compared ivonescimab versus pembro, and there was a huge PFS difference of around more than 5 months. And you can see that the benefit was consistent in patients with a PDL1 score of more than 50, and also in patients with PDL1 of 1 to 50%. The overall survival results are not yet reported. It is immature as of now. So there were a few criticisms regarding the study. So I just need to highlight 2 important points. One is that this was only a single center study. This was done only a single country study. I'm sorry. So this was done only in China. This was not replicated till now in other countries. And another important point is that you can see that in PDL1, 1 to 49%, if you actually see, your Pembro alone is not the standard of care. So it has already been proven that your pembrolizumab plus chemotherapy does better than pembrolizumab alone in PDL1, 1 to 49%. So comparing your ivonescimab with Pembro in that subset is not, I mean, it should not be the way to go, I feel. So you just need to know these two caveats associated with Harmony 2. And again, Harmony A, this is a smaller study. So here what they've done is they have taken EGFR positive patients who have progressed post an EGFR TKI like an osimertinib, and they have taken, they've compared ivonescimab plus chemo versus chemo alone. So again, here they've shown that your ivonescimab combination has got a PFS advantage over your chemotherapy alone. So again, this is one another combination that you can try post EGFR TKI. So this list actually keeps on growing and growing. So you have your a few slides back, I had mentioned about patritumab deruxtecan, then your amivantamab plus lazertinib combo, amivantamab plus chemo combo, then your ivonescimab and there are two, three more drugs that have been tried in this post EGFR setting. So now let's shift our focus to sarcomas. So here I'll be discussing few drugs. So first, let's talk about vimseltinib. So vimseltinib, it is a recently approved, FDA approved drug for symptomatic TGCT. So TGCT, as you all know, it is a newer term for your pigmented villonodular synovitis. And this, what is the mechanism of vimseltinib? It is a oral switch control kinase inhibitor. It selectively inhibits CSF1R. So students must all be knowing that the classical alteration associated with your TGCT is your COL6A3 CSF1R alteration, and your vimseltinib specifically targets this. And the drug has to be taken continuously. The 30 mg BD is the dosing. And the important thing is the side effects. So basically, it can cause your increased blood creatine phosphokinase enzyme levels. And so, why is vimseltinib so special? Because the previously approved drug, so that was pexidartinib. So, if you can compare these two drugs, your response rates are pretty much the same, around 30 to 40%, and your duration of response is also same. But the main issue with pexidartinib was the hepatotoxicity. So, this was actually a black box warning associated with pexidartinib. So, vimseltinib compared to this, that drug does not have this side effect. And we have a phase 3 trial with vimseltinib, that is the MOTION trial. So again, this was published recently in the Lancet Oncology. So let's come to avapritinib, not that newer drug, but I thought I should mention it for the exam goings. So what is avapritinib? Avapritinib again is a type 1 kinase inhibitor, activity in relapsed refractory GIST. What does it target? It specifically targets your PDGFRA, D842V, and KIT D816V. So what is special about these two mutations? Because these two mutations are considered to be resistant to your conventional TKIs in small molecules like imatinib, sunitinib, and regorafenib. So the recommended phase 2 dose of avapritinib is 300 mg OD. This was approved around 5 years back for GIST. And you all must be knowing that KIT D816V is a classical mutation that is associated with your systemic mastocytosis. So avapritinib is also approved for that. And what are the important side effects with avapritinib? Two important side effects. One is your cognitive impairment and your intracranial hemorrhage. So let me discuss just two landmark trials with avapritinib. One is your the phase 2 study, that is a Navigator trial. So Navigator trial, they've taken recurrent GIST with PDGFRA 842B, and here they've shown that the response rates are up to the tune of around 90% with a median PFS of around 34 months. So that is actually huge. The benefit is too huge with avapritinib in your D842V. And then avapritinib was compared with regorafenib in the phase 3 Voyager trial. So this is a very important study. The main conclusion from this trial was that here they've not taken D842V alone. So they've taken the entire GIST population with a mix of all different mutations, and they've shown that the entire population there is no difference between avapritinib and regorafenib. You can see that the PFS was around 4.2 months versus 5.6. But if you take the D842V subset separately, you can see that the difference is huge. The benefit was so much better with your avapritinib compared to regorafenib. So yeah, so let's come to ripretinib next. So what is ripretinib? So ripretinib again, it is a newer molecule. It is your FDA approved fourth line in your recurrent metastatic cyst. So it has got a unique mechanism of action apart from your other conventional drugs. So it is a switch kinase inhibitor. So what do you mean by switch kinase inhibitor? So basically your main two receptors in your gist, that is the KIT and the PDGFRA, they are controlled by two switch control regions. One is present at the inhibitory pocket at the juxtamembrane domain, and another is present at the activating switch in the activation loop. So the dose is around 150 mg BD. So let me discuss two important trials. So yeah, a word to my junior colleagues and the exam goings. You need not know much in detail about these trials. Just the name of the trial, what were the study arm and the comparator arm, and what was the benefit. That is it. So Invictus trial, it was the first trial which compared ripretinib versus placebo. There was a PFS advantage of around 5 months with ripretinib. And so, what was the classical adverse events associated with ripretinib? Mainly, it causes elevated lipase enzymes, but no clinically significant incidence of acute pancreatitis. It also can cause hypertension and hypophosphatemia. So now we have Invictus, placebo-controlled trial, benefit with ripretinib. That is a PFS benefit. So let's come to the next trial. So after this, uh, Sebastian Bor and colleagues, they conducted the INTRIGUE trial. In INTRIGUE trial, they've compared ripretinib versus sunitinib. And unfortunately, in this trial, there was not much difference between ripretinib versus sunitinib. So you can see that the PFS difference was to the tune of around 0.3 months. It was not significant. There was a slightly increased response rates with ripretinib, but overall, the study was negative. So then let me introduce this brilliant paper in which came in Nature 1 year back. So here, what they've done is that they have conducted a ctDNA biomarker exploratory analysis from the INTRIGUE trial. So they have here broken down the patients from the INTRIGUE trial into two subsets. So basically, they have shown that patients who had mutations in the exon 13-14, that is the ATP binding pocket. So those patients, they benefited from sunitinib, and those patients who had a mutation in the activation loop, that is the exon 17 and 18, those patients benefited more with ripretinib. So after this paper, it was much clearer in what patients to use your ripretinib better. So let's come to desmoids. So let me introduce narrowgesistat. So you all know that desmoid tumors are characterized by mutations in the WNT beta-catenin pathway. They are the most common mutations seen in around 90% of desmoids. So along with your beta-catenin expression, desmoids also express Notch1. So what is the importance of Notch1 in desmoids? So the crosstalk between the Notch and the beta-catenin, it helps in the proliferation of your desmoid tumor cells. So your narrowgesistat is a gamma secretase inhibitor. It prevents the release of your intracellular notch. So I know these names must be intimidating for all the exam going students, but you just need to remember the name and the mechanism. That's it. And so it is FDA approved. So it is FDA approved for progressive symptomatic desmoids, and it is actually currently the first line. So before, the first line for your progressive symptomatic desmoids was sorafenib. So from sorafenib, now we are slowly moving on to gamma secretase inhibitors. So this was the landmark DEFI trial, which was published in NEJM 2 years back. So this was a placebo-controlled trial where they have compared narrowgesistat with placebo. Here they've shown that the 2 year EFS was around 76% in the narrowgesistat arm versus 44% with placebo, and response rates are to the tune of 40% in narrowgesistat, with around 7% of patients achieving a CR. And one very important thing is you should remember this classical toxicity associated with your Notch1 gamma secretase inhibitors. So that is the premature menopause or your reversible ovarian toxicities. So this is seen around, it is reversible in around 75%. So while counseling your young patients and your female patients with narrowgesistat, you should always mention the side effect before you start this drug. So coming to tebentafusp, you all must be aware of this drug. This had come a few years back. So this is the only FDA approved first line for metastatic uveal melanomas. So what is tebentafusp? So tebentafusp is an IMTAC. So what are IMTACs? IMTACs are your immune mobilizing monoclonal T cell receptors. So in short, it is basically an HLA restricted therapy. So it is mainly restricted to your patients who express the HLA A0201. So this specific HLA repertoire, it is actually seen in only around 10 to 15% of Asian populations and around 50 to 60% of your Western, European and US populations. So if somebody asks you tebentafusp, can you give it as a first line for your patients here? Yeah, the answer in simple terms is no. it is only beneficial for the select around 5 to 10% of your Indian populations. So, and that must be one of the reasons why this drug was not further developed here. So it is specific for your GP100, which is present in your uveal melanomas. And this has got a step-up dosing. And side effects are easy to remember. It is just like your other impacts. The main side effect is your cytokine release syndrome, but the majority are grade 1 and 2. Again, this is a landmark NEGM paper where they have compared tebentafusp versus your existing standard therapy in uveal melanomas at that time. That was only your IUs and your dacarbazines. So basically, tebentafusp overperformed the immuno-oncology drugs and your conventional chemotherapy drugs. So coming to GU, so I will be discussing only belzutifan and GU because the other drugs have been wonderfully covered by my colleagues in the previous sessions. So belzutifan, one of the potential blockbuster drugs of the century. So it is an HIF2 alpha inhibitor. So it is currently FDA approved in metastatic RCC. And they might ask you in what setting it is approved, as a first line or your post one line, two lines. So as of now, the approval is post PD-1 and post VEGF. So where was belzutifan initially tried before it came into your conventional RCC? So basically, it was tried as a surgery-sparing strategy in your VHL patients. So that was the LightSpark 002 study where it has shown a huge benefit in your VHL patients. So the problem with VHL patients was that they have an incidence of around 70% of developing your clear cell RCCs, and the problem with that. Once the patient goes in for a surgery, the chance of recurrence is to the tune of 50 to 60%. So patients during their lifetime, they need to have multiple procedures, whether it be your renal resections, your resection of your pancreatic NETs, or your cerebellar angioblastomas. So once the patient was put on belzutifan, the response rates and the duration of response was so huge that it could reduce the incidence of the surgeries that were being done. So this was the initial indication of belzutifan. Slowly, it came into your clear cell RCCs also. So the dose is 120 mg. The two important side effects. One is the hypoxia, symptomatic hypoxia, and anemia. So basically, it's easy to remember. It is a class effect of your HIF alpha inhibition. So there is nothing special with that. So this was a landmark trial published in NEJM. Here they have taken clear cell RCC patients post IO VEGF. So here they've shown that the PFS actually in this trial was similar in belzutifan versus everolimus arm. So because this trial it did not specifically follow the routine Cox proportional model, so they had to use a restricted mean survival time while calculating the hazard ratios and your PFS. So the PFS was similar, but your response rates was higher in favor of belzutifan, and overall survival as of now it is not significant yet. So OS is around 21.4 versus 18.1. So in short, if somebody asks you is belzutifan for everyone, so my answer would be belzutifan benefits a small section of patients, but for those patients who benefit out of them, the ones who respond, they respond for a very long time. So this was the study that I talked about, belzutifan. This was recently published, the long-term results of belzutifan in VHL patients. So in around 61 patients of your VHL-associated RCC, around 70% of them responded, and they responded for 3 to 4 years. So these are some of the studies with belzutifan that you need to be aware of, which are currently ongoing. So one is the initial combination with belzutifan. So the LightSpark 003 trial, where they have combined belzutifan with a TKI. So in that case, it was cabozantinib. So belzu plus cabo. So that is being tried in the LightSpark 003 trial. And it is also being tried in combination with pembrolizumab as an adjuvant post-resection. So that is the LightSpark 022 trial. So that those results are not yet published. So coming to GI, so this I guess will be my last section. So in GI, I'll be discussing few drugs. So first, let me talk about zolbetuximab. So zolbetuximab, as you all must know, it is a novel chimeric IgG1 antibody against Claudin 18.2. So Claudin 18.2 is seen in around 30 to 40% of HER2 negative metastatic CS stomach, and basically it exerts by mediating your ADCs and your CTC, and it is FDA approved in combination with chemotherapy. And the dosage, I would not urge the students to buy hard the dosage. So just remember this fact that zolbetuximab is highly emetogenic. So I can share it in the ISMPO rooms. There was a special paper that came in Annals of Oncology on how to deal with your zolbetuximab induced chemotherapy, zolbetuximab induced nausea and vomiting. So the main reason that they quote is that the zolbetuximab, the first infusion itself will cause so much gastric mucosal distension that it preponds for huge incidence of CINV. So zolbetuximab was mainly tried in two trials. So you just need to remember the names and the comparator arms. So one is the Spotlight trial. In the Spotlight trial, zolbetuximab was combined with chemo, your 5-FU platinum-based chemo. So in this case, it was FOLFOX. So zolbetuximab plus FOLFOX. It had a PFS and an OS advantage. So OS advantage was to the tune of around 3 months, 18 versus 15 months. So next is the glow trial. So glow trial, it is Capox. So this is quite simple. So Spotlight with Folfox, glow with Capox. Similar benefit. It's around 3 to 4 months of overall survival benefit. So let me come to bemarituzumab. So let me first tell that bemarituzumab is not yet FDA approved. Zolbetuximab is. So, what is bemarituzumab? So, bemarituzumab is a first-in-class monoclonal antibody which specifically binds to FGFR2b. So, what is special about FGFR2b? So, FGFR2b, again, in HER2 negative CS stomach patients, it is seen in around 30%. So, how do you test it? So, is it an IHC based? It is a sequencing. So, as you all know, FGFR in your cholangioes, it is basically your rearrangements. So, you test it by sequencing your RNA fusions. But in stomach, it is basically for bemarituzumab. The approval is basically for increased IHC expression. So patients with an expression more than 10 percentage FGFR2b, bemarituzumab is being tried. And the trial is a small phase 2 study, a small number of patients. It is a randomized fight trial. Phase 2 study where bemarituzumab was combined with your FOLFOX, and there was a PFS advantage of around 2 months, and your OS was around 19 versus 13, so around a 5 to 6 months delta. But I wouldn't read too much into this data because we need much larger patient population. We need a phase 3 trial and an approval before we can try this in our population. So we just need to know that there is this drug called bemarituzumab. It targets FGFR2b. The approval is through an IHC based approach, and yeah, that's it. So let's come to zanidatamab next. Zanidatamab. So what is special with zanidatamab compared to your other ADCs? So basically, it is a biparatopic, bispecific antibody. So what is the meaning of biparatopic? It means that it targets two distinct HER2 epitopes. So what is the importance of this dual epitope targeting? So it leads to better cross-linking, clustering, internalization, and it leads to a better inhibition of cellular proliferation. So again, your zanidatamab, it was tried in the Horizon BTC trial. So this was recently published in the Lancet Oncology. This was a single-arm phase 2 trial where they've shown that zanidatamab in your metastatic HER2 amplified BTCs, it leads to a response rate of around 50% and an excellent duration of response. Again, another setting where the responders, they respond for a very, very long time. The duration of response was around 15 months with zanidatamab. And your side effects, again, compared to the other anti-HER2 targeting agents, it is your diarrheas, your infusional reactions. So nothing much special with respect to the side effects. Again, zanidatamab was granted accelerated approval by FDA recently for your previously treated metastatic HER2 positive BTCs. And there are a lot of trials of zanidatamab which are currently ongoing in our country. So coming to fruquintinib again, an option that can be given for your metastatic CA colon patients relapsing post 2 to 3 lines. So what is fruquintinib? It is a highly selective pan-VEGFR receptor inhibitor. It inhibits VEGFR 1, 2, 3. It comes in 5 mg capsules. You need to know the dosing. So it is much like capecitabine. You give it for 3 weeks and you give a 1 week off period. And the most important side effect is hypertension. So the hypertension, in the actual trials, there were a few instances of death also that were attributed to hypertension. So incidence of hypertension with fruquintinib is much higher compared to your other small molecule TKIs like your lenvatinib or your cabozantinib. And it is FDA approved. So the trial which tested fruquintinib versus placebo was your FRESCO trial, and your the OS delta was to the tune of around 2 to 3 months. And where would you give fruquintinib for your patients? I would preferably give it in the fourth lines post your FOLFOX, your FOLFIRI, your sunlight regimen, and your regorafenib. So post those lines, you may try fruquintinib. So coming to, yeah, breast will be my last session. Just I'll be discussing 1 or 2 drugs. So elacestrant, not that new. So what is elacestrant? Elacestrant, as you all know, is an oral SERD, selective estrogen receptor downregulator. So you all know that your first line metastatic CS stomach patients, you start off with your CDK4 plus your ET. So that is your first line. So what to do when your patient progresses or PDs on your CDK4 ET combination? So again, if you're not testing your patients for specific mutations, you give your Bolero 2 regimen with your everolimus exemestane, or if you're testing for PIK3CA, you switch them onto an fulvestrant alpelisib combo. And if the patient has an ESR1 mutation, you switch to elacestrant. The drug is currently not available in our country. So elacestrant was tested in the landmark Emerald trial with standard of care. So here they've taken women with advanced metastatic breast cancer, ER positive. They need not have received chemo. Only the inclusion was less than 1 line of chemo, but more than 2 lines of endocrine therapy. They were randomized to elacestrant versus your standard of care. So that was your anastrozole, letrozole, exemestane, or fulvestrant. So here they've shown that elacestrant had a PFS advantage of around 3.8 months versus 1.9 months. It had provided a 45% reduction in the risk of progression or death compared to your standard of care. So this is a very, very important slide. So this, I just wanted to highlight that. So if you see these three curves, so patients who are getting more and more of patients who had responded well to your CDK4 inhibitors. So those are your patients who will respond better with an elacestrant. So here you can see that patients who have received at least 1 year of prior CDK4 inhibition. So they have a huge advantage with elacestrant. The PFS was around 8.6 months compared to 4 months when your patient progressed early on your previous CDK4. So again, side effects are not that alarming. Mostly grade 1, 2, your nausea, vomiting, and your fatigue. There were no grade 4 side effects with elacestrant. A word about capivasertib. Capivasertib, again, it is FDA approved. It is an AKT inhibitor. It was mainly tried in the Capitulo 291 trial, where they have compared where they've compared capivasertib plus fulvestrant versus fulvestrant and placebo. And here they have shown that capivasertib combination had a PFS advantage. It was around 7.2 months versus 3.6 months. So here in this trial, they have taken the whole entire population together, and they have the ITT population. So they have also separated out the AKT pathway altered population, in which the hazards were even better with capivasertib. So again, the dosing is capivasertib is not available again, just like elacestrant, it is not available in India. The dosing is 400 mg BD, 4 days on, 3 days off regimen. So in November 2023, it was granted approval by the FDA for AKT pathway altered tumors. So yeah, this is my last slide. So this is kind of like a money slide where you get a view about all the major options that are available post your CDK4/6i. So just like I told you, if you're not testing for specific mutations, you have your everolimus exemestane combo. But the Bolero 2 trial, if you can see that this was a very old trial, so none of the patients received a CDK4i in this study. So PFS was around 10 months. So coming to Solar 1 was the trial where they've tried fulvestrant plus alpelisib versus fulvestrant. So here again, this was the trial finished accrual before the CDK4/6 became widely popular. So around 95% they did not receive any CDK4. So if you can see that the PFS was around 11.1, 11 versus 6.8 months. But if you see that the patients who received prior CDK4i, the PFS drops down. It drops to half. It is around 5.5 months versus 1.8 months. Again, coming to Capitulo 291, here around 70% received CDK4i. So for those patients who have received CDK4i, again, your PFS drops to around 5.5 versus 2.6 months. So yeah, that's pretty much it. So yeah, this is my last slide. I just wanted to end with a small quote from one of my favorite role models, Rafael Nadal. So to all my junior colleagues and the students who are going for the examinations, you endure, put up with whatever comes your way, learn to overcome weakness and pain, and push yourself to breaking point, but never cave. Yeah. Thank you.
Thank you, Dr. Akhil. You have truly justified being the speaker of this topic. And to the examinee, don't get overwhelmed with all these new data which you have just got. You actually keep all these slides as a treasure, because these slides will be used in future for like next 4 5 years when you start using these drugs in your practice, and we get these drugs in India and we start using these drugs. Then I would like to invite Dr. Amol Akhade, and I'm sure every medical oncologist in India knows him, and he is internationally known, and we all know how critically analyzes all the articles. and he will be the true examiner. And if you go, if you have like, if he passes you today, that means you are actually passed in your DNB exam or DM exam. Welcome, Dr. Amol. Over to you.
Yeah, thank you. Thanks for kind introduction. And it was an excellent presentation by Akhil, and he had definitely covered most of the new drugs. And as Saphalta said, these slides are treasure worthy. So can I allow, can someone allow to share my screen? I need to share my screen. Okay. Am I allowed? Are my slides visible? Are they visible?
Yes, sir.
Yes.
Yes, sir.
Yeah. So I can see two of the students. Dr. Yash, you are from which institution? Sorry. You are
Yes,
unmuted.
sir, from TMS Bombay, Tata Memorial Hospital, Bombay.
And Dr. Raghuram, you are from?
Sir, I am from TMC Kolkata.
Fantastic. So we have, I think, time up to 3:30. I have a lot of slides, but whenever the time is up, please let me know. We will stop this. So let us start. I have no conflict of interest to declare. Aim of this presentation is to make students sensitized to read in more depth, develop and habit to arrange data in a structured manner so that they can remember it and apply it. Please understand oncology is vast, and mind you, it will keep becoming more and more vast. So you have to keep updating yourself. And please remember the last word, you have to keep updating yourself forever because you have chosen to become a medical oncologist. So you have to do this forever. So moving on, my 2 cents for drug viva. It is technically the toughest part of the exam, as it can go in any direction, any depth. Generally, its impression is already set by this time on long and short case, but decision for mercy, so you want to pass somebody, or you want to give extra marks or distinctions are made during drug viva. So it is an important thing. And yes, you can get brownie points, extra marks. So drug vivas are important. As a medical oncologist, you must know drugs in depth. You're supposed to know name, dose, mechanism of action, indication, toxicity, dose modification. But at the DM and DRNB level, you need to know beyond this. Please understand, generally, drug viva occurs on basic cytotoxic drugs most of the times, or maximum on MABs or IOs. Generally, your viva will never reach to today's topic of newer drugs. And if it reaches, there are only two possibilities. Either you're doing extremely well, or the exam board of asking you questions on basic drugs. So that is what happens. So let us start. And I don't believe in spoon feeding because, as I have shown here, the spoon feeding in the long run teaches us nothing but the shape of the spoon. So at our level, we are not supposed to have spoon feeding. So I'm only going to provide you questions, and you will have enough time to find the answers. And if you cannot find the answers, then you can get back to me anytime. And I request only these two who are chosen to give the viva should answer. Rest of the people don't type anything in the chat box. You can do that at the end of it. So this is generally, sorry, the expression of the students. Am I visible? Yeah. So this is how the students look during the exam. They start like this, and then they have this different looks. So what we are right now doing is playing a cricket match on a video game. What happens in the real exam is playing cricket match in the real stadium, and that is definitely more stressful. So let's start. So my first question starts with Dr. Raghuram. The R comes before Y, so alphabetically. What do you mean by term synthetic viability? Can you name any drug in oncology or situation oncology which works on this principle of synthetic viability? Dr. Yash?
Yes, sir.
What is any guess? What can be synthetic viability? You have heard a similar term probably. Have you heard any similar term?
Lethality.
Synthetic lethality. You have heard synthetic lethality.
Lethality.
So,
Yes, sir.
yeah, synthetic lethality you have heard. Fantastic. So at least I will pass you. But can you then tell me what is synthetic viability? Because when I say why I'm asking this question, because when you read something, you are at the DM and DNB level. You're supposed to go into depth. You're supposed to find out what is the concept of synthetic lethality, and then can be something else. So we'll go to the next slide. So do you know the other terms? What is collateral lethality? What is synthetic dosage lethality? What is redundancy targeting or functional buffering? These are all comes with synthetic lethality. This can be asked in theory. This can be asked in Viva. Any idea?
No, sir.
Okay. Fine.
Collateral.
So I will ask a simple question. You say something? Somebody saying something? Okay. So do you know, of course, synthetic lethality is associated with PARP inhibitors. Can you explain what is synthetic lethality? Synthetic lethality is there in textbook, yeah. It's there everywhere.
So, sir, basically, PARP inhibitors work by inhibition of the PARP, basically, which is a. So there are two pathways of DNA repair. One is the double-stranded pathway of DNA repair, and the other one is a single-stranded pathway of DNA repair. PARP is one of the single-stranded pathways of DNA repair. So, by inhibition of PARP inhibitors
So let us understand. Let us understand what is synthetic and synthetic lethality.
we are
What is synthetic?
we are using agents. I mean, we are using drugs to create this lethality externally.
So can you explain it in more detail? And the question is, of course, you know PARP inhibitors. Do you know any other drug apart from PARP inhibitors which works on the principle of synthetic lethality? That is the question. And if you know synthetic lethality, then you should know collateral lethality, then you know synthetic dosage lethality, then you should know synthetic viability also. And opposite of it. Synthetic viability is opposite of synthetic lethality. Okay. So you all will read about it. And that is the funda of this particular discussion, that you should understand the topics that you need to read in more depth so that you know this. We'll move on to the next set of questions. Do you know what is cryptic antigens? What is the word cryptic means?
Cryptic means it is not expressed in. It is not expressed.
So,
not
for
expressed.
example, I will give an example. I will give an example. Is EGFR, suppose we take our blood sample and we test it, or we take our lung tissue biopsy and test it. Will you get EGFR on it, or will not get?
We'll get EGFR.
Or we will take a stomach biopsy. Will you get HER2 on it? So basically, are these normally expressed? Are these antigens normally expressed? HER2, EGFR, are these normally expressed?
Yes, sir. They are normally expressed.
Yes, sir. Normally expressed.
So what is cryptic can be? Cryptic is something which is not normally expressed, but will be expressed in cancer tissue. Okay, so why it is not normally expressed, but it is somewhere hidden. And when malignancy occurs, it comes on the surface. And that is what is the importance of this? Because, of course, there is a drug. So, I've given the hint. What is DLL3?
DLL3 is
one person answer there. Yash, can you answer? What is DLL3?
It is delta-like ligand, I think, sir.
Delta-like ligand 3. Yeah, D is always for delta. So this is a cryptic antigen. It is not normally present. But what is the significance of DLL3? What do you know the drug is acting on? Why this drug is making the headlines recently?
So there is a tarlatamab, I think, which is a bispecific T cell engager, which binds DLL. One of the ends binds to DLL3 and the other engages the T cell.
So, but why it is making the headlines recently? Dr. Raghuram?
So it's recently approved in the management of. I'm not able to recollect the
It
exact
is
disease.
it is used in
Which cancer?
NSCLC.
NSCLC?
Small cell lung cancer.
Small cell lung cancer, yes.
There are only
In
two cancers,
metastatic
non-small
small
cell,
cell
small
lung.
cell. Are you sure? Small cell or non-small cell?
Yes, sir, small cell.
Small cell.
So it is one of the drugs which has shown the OS advantage as per the press release in the second line of small cell lung cancer. So that is why it is making headlines. And why DLL3? It's not normally present. If you take a normal lung biopsy or lung tissue, it will not be seen on the surface. It is present in the Golgi apparatus. And when the malignant transformation occurs, it comes to the surface of the cancer cells. So it is cryptic antigen. And that is why it is supposed to be something that is new. And that is why I will ask the question. So let us move on. I want you to note this terminologies, topics, and I want you to read them so that you can read in more depth about them. So let's move on. So Dr. Raghuram, is bispecific and bite of same or different? Can all bispecifically bite and the vice versa?
So, not necessarily. Bites are bispecific T cell engagers in which the receptor on the
So
surface
let
of
me ask.
the
Okay, what is the long form of bite?
bispecific T cell engager.
Okay, so are all bites bispecifics or all bispecifics can be bite? So which is a bigger subclass, which is a smaller subclass?
So all bites are bispecific antibodies, but not all bispecifics are not bites.
Yeah, fantastic. Good. So what is biparatopic ADC?
They can be acting on.
Akhil showed you some example.
It's an ADC on which the monoclonal antibody has. There are two parrot. I'm not sure.
So what is this? What is paratopic? Bias two,
there
of
are
course,
two.
no, everybody knows. So what is paratopic?
Same.
So what is
There
the
are
difference
multiple
between the
paratopes.
bispecific? So what is the difference? You have to explain me what is the difference between
bispecific
bispecific
antibody.
ADC and biparatopic?
Sir, bispecific antibody binds to two different receptors. Whereas biparatopic binds to two epitopes of the same receptor.
Okay. So what is tetravalent bispecific? Or monovalent, bivalent? This
So
again,
these are
Akhil
the
has shown you the bispecific drugs which acts on both PD-L1, CTL4. Akhil has shown this.
Yes, sir.
So what was that drug?
Canolimab.
Candolimab.
Candolimab.
Cadonilimab.
So what is
Cadonilimab.
tetravalent? So what is tetravalent bispecific? Tetra is 4, na?
There are bispecific antibodies in which 4 different antigens can be attached to the antibody.
Or they can attach to the same antigen at 4 different sites. I'm asking you. Okay. So we'll find out all these terms. You have to be very thorough with these terms because if you know them, see what is going to happen. The newer and newer drugs are going to come. There are at least 100 ADCs which are in trial, out of which 10, 15 will make it to phase 2, phase 3. So you need to know the basic classification first. And once you know the basic classification, then you can arrange the information in each of the particular subtype. So whether it is bispecific, biparatopic, tetravalent. What is BTC? ADC stands for, what is the long form of ADC?
Antibody drug conjugate.
Antibody drug.
So what is BTC? Don't tell me biliary tract cancer.
Yes, sir.
So write down. What is dual payload ADC? This dual payload ADC was shared in the WhatsApp group few days back. If I'm part of the WhatsApp group, ISMP WhatsApp group, it was shared by somebody else. So please understand, loads of new drugs are going to come. When I gave my exam in 2010, the IO was not approved. In 15 years, IO are gone, and we are talking about ADCs. And another 10 years, ADC will go, and we'll talk about BiTEs. So medical oncology is evolving rapidly. You have to keep yourself updated. And this may not be asked in the exams, but I don't think so the Viva will reach that level. But as a knowledge part, you need to. I'm telling you, there's some examiners have tendency to ask such questions. When I was exam going, Dr. Sagar, who is the retired professor now from Adyar, was supposed to come for the exam. So we tried to find out what kind of questions he asks. So somebody told us his favorite question is, he starts, do you know ATRA? And then, of course, that time in APML, ATRA was used. So people used to answer, yes, sir, we know ATRA, we are given ATRA, blah, 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 blah. Then he used to ask the googly question. What is the shape of the ATRA tablet? What is the color of the ATRA tablet? And why it is kept in a dark bottle? And if you don't know this, they will tell, oh, that is not actually it. That means you're not given it. So because you know this, of all the action that are prior sitting, am I still audible or am I stuck? Audible? Can someone tell me, am I audible?
Patchy.
You're
Sir, it's
breaking up in
patchy.
between, yes. You're
I
audible,
guess
but
there's
you're
a break in the voice, sir.
yes.
Yes, sir.
So probably you can switch off your video and only the audio can make it a little better. Saphalta ma'am, in the meanwhile, if you
Am I back?
can ask
Sorry.
a few. Yes, sir, you're back. Probably you can
Back.
switch off your video and it'll help us, streamline the audio a bit.
Okay. So, okay, I will start sharing the screen. I don't like Zoom meeting there, but anyways. So, my slides are visible. So,
Yes, sir.
yeah. So we'll move on to the next question. A simple question. Yeah, we'll ask Dr. Raghuram. You just have to tell me the mechanism of action of these three drugs.
Sir, I will.
I've chosen these
Sir,
three because they are similarly sounding.
Yes, sir. Sir, the second one,
So,
IOC
first
is
one,
the
first one.
IDH1 inhibitor.
First one is what?
Sir, it's a bispecific monoclonal antibody. It is targeting the PD1 and the anti-VEGF, sir.
Okay, next.
So ivosidenib is a TK, is a targeted therapy in which it's a IDH1 inhibitor used in the management of gliomas.
And then the last one.
I'm not aware of that, sir. Sorry,
Dr. Yash.
Pick 3, sir, from the name. Elicit pick 3
Inhibitor.
P inhibitor.
Okay. Dr. Yash, what is IDH stands for? It is IDH or LDH?
Isocitrate dehydrogenase.
Where have you read this in your MBBS?
Krebs pathway, sir. I mean, generally speaking.
Fantastic. Okay.
Krebs
So you
cycle.
know the Krebs pathway. Good, yes. So it was there in the Krebs pathway. Fine. So let's move on to some. What is the difference between repurposed drug and drug reformulation?
Repurposed
What is
drugs are drugs,
repurposed?
sir, which, sir, drugs, conventional drugs which were used earlier, then
So
rediscovered, their use was rediscovered for some other indication.
what is non-conventional drugs? All drugs are conventional only. We are not talking about
No, yes, sir.
recreational drugs here. No? So,
Yes, sir.
so
So they were manufactured for some indication. They were taken out from that indication, and then they were found to be useful in another indication.
for example, exotic example in oncology. And what is reformulation?
Repurposed drugs are maybe thalidomide.
Thalidomide is repurposed. So what is the original purpose?
Not sure.
A repurposed drug is drug which is used for another disease totally. Say like diabetic drug which is used for cancer treatment, or an antihypertensive drug which is used for cancer treatment. That is repurposed. What is reformulation? Reformulation is the latest trend. A lot of drugs are getting reformulated.
Liposomal formulation or something like that, sir. Not
Okay,
sure.
so which liposomal formulation is right now making a wave?
Irinotecan, liposomal irinotecan.
Docetaxel.
Okay. So that is reformulation. So any drug that you know which was once used as a poison and now it is a landmark anti-cancer drug. Once upon a time it was used as a poison. And probably still used. I'll give you a hint. One of the famous kings was killed by using this drug. Atra is not a poison, boss.
Napoleon.
Arsenic trioxide.
Fantastic.
Napoleon.
Fantastic. So Napoleon, arsenic trioxide. Fine. So now let us come to the real life question. Imagine you're sitting in a big corporate hospital, you got your degree, and one rich patient comes to you for second opinion. He said he used one costly imported drug for his wife, but now the vision has reduced. What can be this drug and how it reduces the vision?
So anti-folate alpha receptor ADC.
Which one?
Marvetuximab soravtansine, maybe.
EV, then this.
EV causes reduction in the vision.
It causes retinal issues.
Okay.
So
which is more common?
So now the drugs are
Akhil discussed this.
tisotumab vedotin,
Okay,
sir,
that is
EV.
okay. So how mirvetuximab and tisotumab are the two drugs, and how they cause reduction in the vision? How mirvetuximab causes reduction in the vision?
It causes corneal opacity and keratopathy mainly, sir.
How? वो तो ओवरी का कैंसर का ड्रग है ना, वो नीचे काम कर रहा है, वो आंख में कहाँ से जा रहा है? Any other drug in myeloma that you know which causes? So what? So folate receptors, तो क्या methotrexate से blindness होता है? Methotrexate is also anti-folate drug. उससे तो blindness नहीं होता है, तो फिर ये mirvetuximab से कैसे होता है? How?
Probably folate receptor alpha related, sir.
मतलब folate receptor कितने होते हैं? If you answer this, then exam is going to catch you. But alpha, beta, gamma, delta कितने होते हैं? In exam, if you know the answer, you should answer. Here, you can, of course, guess. This is not a real exam, but in real exam, you have to either say, yes, I know, or I don't know. Any myeloma drug which causes this? Blindness or decreased vision, not exactly blindness, decreased vision. Newer myeloma drug which was initially thrown out, then it has now come back.
Selinexor.
Okay, so we'll find out all this. Which one?
Selinexor.
Selinexor doesn't cause blindness. No, Selinexor doesn't cause blindness. Or retinopathy or decreased vision. So you note down the questions. Okay, now let us a simple thing. Ekdam basic. What is the subacute dose of trastuzumab for metastatic breast cancer?
So,
Okay, trastuzumab is available in subacute form? Yes, no?
It is not in our
Yes or
hospital.
no?
yes.
No. Not in our hospital, different thing. What is the dose of subacute trastuzumab?
I don't know.
No worries.
Okay, can you name some drugs which are available in both IV and subacute form? Anti-cancer drugs, of course.
Pembrolizumab, amivantamab,
And
Cytarabine.
bortezomib,
cytarabine. Okay, so
azacitidine.
okay, so do you think that the dose is different for the IV and subacute, or the dose are same? The
It
dose
depends
of
from drug to drug.
dose of, so tell me for which drug the dose is more, for which drug the dose is same. And if you know any drug,
Sorry,
the dose is less.
for the combination of pertuzumab trastuzumab, the dose will be more in subcut.
Okay, in any other drug, what the drug dose is more. What about nivolumab, pembrolizumab, or atezolizumab? The dose same or different? Okay, tell me the other way around. For which one will have the same dose? Both IV and subcut.
Azacitidine, bortezomib, same dose.
Azacitidine.
Azacitidine and bortezomib have same dose. So why azacitidine and bortezomib have same dose, but the others have higher dose?
More of first pass metabolism in the skin.
Okay. So what? So what is that principle doesn't apply to azacitidine or bortezomib? Okay. Do you know generally the subacute form comes later, IV comes first. So let me. There are two questions here. Do you know any drug whose subacute form has better OS than IV? Better OS in a randomized trial.
Sir, amivantamab is same, I think. Better PFS with lesser toxicities. I'm not sure about OS.
Any other drug? So what is the advantage of subacute? What they say? What is the advantage of subacute? Advantage to the
less
patient,
hospital.
not to the company.
More convenient to the patient.
So does it improve survival?
It should improve the quality of life. I mean, I'm not sure.
So does any of the subacute form improve survival as compared to the IV form? So we'll find it. So now the last question in this route of administration. Tell me one, in most of the drugs, the subacute form comes later. IV comes first. In which is the one of the few drugs in oncology in which the subacute has come earlier, and now in certain situations we give it IV also and it works.
Daratumumab.
I will give you a hint. It is root. Daratumumab is given subacute and IV both, and the IV form came first, subacute came later. I'm asking the other way around. The subacute formulation came first, and now we use it in IV for certain situations. So we will find out. Let me know whenever the time is up. I have a lot many questions. Okay, this is again simple question. What is the dose of trastuzumab deruxtecan in advanced stomach cancer? Is it approved in advanced stomach cancer or not? Metastatic stomach, is it approved or not approved? It is approved. So what is the dose?
It is approved.
What is the
6.4
dose?
mg
Dr.
per
Yash?
Um,
Dr. Raghuram is saying 6.4. Dr. Yash?
not sure, sir. 6.4, I think, but I'm 3 weekly, but I'm not sure.
So what is the dose in metastatic breast cancer, Dr. Raghuram? For trastuzumab deruxtecan?
5.4 5.4 mg per
Ah,
kg, sir.
so why it is more in stomach and less in breast? ऐसा क्या है भाई स्टमक कैंसर में कि भाई आप ट्रस्टोन ड्रग ज्यादा लगाओगे उसमें और ब्रेस्ट में कम लगाओगे?
I'm not sure, sir. I don't know the
Do you
reason.
know any other drug whose dose is different in different cancers? Paclitaxel dose is same, ना? वीकली लगाओ, 3 वीकली लगाओ, ब्रेस्ट हेड एंड नेक में लगाओ, ओवरी में लगाओ, सेम रहता है 770 मीटर स्क्वायर, 80 मीटर स्क्वायर. तो कौन सा ऐसा ड्रग है जिसका डोज डिफरेंट कैंसर में डिफरेंट है? जैसे ट्रस्टोन ड्रग का स्टमक में अलग है.
So cisplatin in biliary
And
tract cancers is
our viva is only of the newer drug.
Oral में cabozantinib, I mean for medullary carcinoma.
lenvatinib. Lenvatinib has different.
Lenvatinib different.
Okay. So why trastuzumab deruxtecan has different dose in stomach and different in MBC? Any guess?
So in breast it's
HER2.
HER2 overexpression, whereas in mainly in stomach it's amplification. I'm not sure, sir.
No. Wait. The stomach, the approval is for what?
Stomach also it's for expression only.
HER2 overexpression.
So what is the approval? What is the approval of trastuzumab deruxtecan in stomach cancer? What is the prerequisite?
HER2.
It is HER2 what?
HER2,
HER2
HER2 3+ or 2+ fish positive.
Okay, so same is for MBC, right?
Yes,
MBC,
sir.
of course, you can use it in 2+, 1+ also. So in
Yes,
fact, in
sir.
MBC, you are using it a lesser expression. So the dose has to be more by that logic.
Maybe because of only
Can
the
you tell?
basolateral staining.
That is with the expression, no? That is how you calculate the score. Okay, can you tell me any cancer in this trastuzumab deruxtecan is approved based on mutation? Forget the expression.
Lungs, sir. NSALs.
Lung. ARPV2 mutation. Lung.
First line, second line, third line, fourth line?
Second line.
Second or third, second line onwards.
Second line onwards. Not sure, first line.
Not in first line.
Not in first line.
Okay, second line is the correct answer. You need to find out why the dose is more in stomach and less in breast. So moving on, suppose you are sitting in a corporate hospital. I wanted to go to corporate hospital, and the dose of trastuzumab deruxtecan comes 240. What will you do with the remaining 60 mg? Take देंगे. 60 mg will cost what? 60,000, 70,000, 80,000. Take देंगे उसको. फेंक देंगे? Both of you want to throw it? और पेशेंट आके पूछ रहा है डॉक्टर साहब 70,000 आप फेंक रहे हो, फिर क्या कहोगे? Okay, anyone to answer or
no, sir, I don't know.
What is the answer?
I don't know.
अरे करोगे क्या इतना तो बताओ, क्यों करोगे तो बात की बात है. What you will do? Okay, simple. After dilution of trastuzumab deruxtecan, are you allowed to keep the remaining or you're not allowed to keep the remaining? Is
Logically
the
speaking,
sharing,
should not have.
is the vial sharing or the using the same vial after dilution is allowed in trastuzumab deruxtecan or not?
Ideally,
Sir,
sir,
What is answer is yes or no?
possible?
no.
No.
So it is not allowed. So in exam, of course, you will say it is not allowed and you will throw the remaining drug. And that is exactly what you will tell the patient also. So the question comes, in which drug it is allowed? You can officially use the remaining portion for the next cycle.
Trastuzumab.
So for trastuzumab it is allowed, but trastuzumab deruxtecan it is not allowed. Why? What is the magic ingredient?
Linker.
ऐसा क्या होता है trastuzumab? क्या होता है? What?
Link, the linker probably. Yeah.
So my question is, you are right. One of the drug in which you can have wild preservation is trastuzumab. So my question is, what is the magic secret ingredient in that allows you to do that, which is not there in other drugs? And the next question is, why it is not there in all drugs? Ideally, we'll be happy that you put that magic ingredient in every vial, and all the vials allow them for not to throw away the remaining drug. There is no drug wastage. So first of all, you should know what is magic secret ingredient. What is there in trastuzumab vial? Was it there in the beginning, or now it has come recently? On the day one, was the vial like that, or day one it was not like that? 1998. So you will find out the magic ingredient.
Yes.
Somebody's keeping the track of the time. Yeah, please tell me when the time is over. So the next, this is my favorite question. What is co-mutation? What is compound mutation?
So we have
Dr.
time.
Raghuram.
We have 30 minutes to.
You have another 30 minutes.
30 minutes. You can go up till 4 o'clock. We don't have any questions in the Q&A till now, sir.
Okay. So he wants you to be grilled for another half an hour. So we'll do that. Don't worry. So what is co-mutation and what is compound mutation?
Co-mutation meaning, sir.
Dr. Yash.
Co-mutation meaning, sir, there are different mutations in two different receptors, whereas compound mutations are two different mutations in the same receptor.
Receptor में mutations होते हैं या gene में होते हैं mutation?
Gene में, yes, sir.
So, Dr. Raghuram,
Yes,
what
sir.
is your definition?
I'll give an example, sir. If
you give example.
Sir, STK11 co-mutation in a KRAS mutated NSCLC. So the main mutation.
What is compound?
What
is compound mutation?
All the mutations are like equally important. Like it's not a component of the main mutation.
For example,
so they can be on different genes or same genes?
Different genes.
Compound के अंदर होना चाहिए, compound के बाहर होना चाहिए.
Same genes. For example, EGFR 19 deletion plus TAT 790M compound.
Okay. So can you tell me drugs acting on compound mutation? The compound mutation is simple to remember. It has to be in compound. It has to be in the same gene. Two different mutations, same gene. Co-mutations are two different genes itself, not the same genes. So drugs acting on compound mutations?
Osimertinib, amivantamab, the newer generations.
Drug acting on co-mutations? One drug acting on co-mutation.
I mean, sir.
Sir, I don't know about one drug, but a combination of drugs can be tried.
No. We have that is a different thing. No? That of course we know. There are two drugs. One drug acting on co-mutation.
So, for example, brigatinib X.
So they are compound mutations or co-mutation?
Which, sir?
The last example that you gave, they are the drugs acting on compound mutations or they are drugs acting on co-mutation?
I mean, sir, they can act on both the receptors. For example, crizotinib can act on ALK and ROS. I mean, they won't usually be co-mutations, but they can act on both of them.
So tell me a situation.
Sorry, sir.
You have a lot of drugs acting on compound mutations. You have a lot of drugs acting on compound mutations.
So, for example, if there is EGFR mutation and a MET amplification, then you can use amivantamab.
Okay, you'll find out. What is PACC mutation?
PACC is So the atypical EGFR mutations. It is
What does
P
PACC
loop,
stands for?
P loop and C helix, something along those
तो A
lines.
क्या है? A is for
A,
Amol Akhade.
no, sir.
अरे obviously
Atypical.
A is for atypical.
No, it is not for atypical.
कौन से कैंसर में लिखते हैं? Which cancer you see?
Sir, EGFR, NSCLC.
NSCL.
It is basically the uncommon mutations that second generation EGFR inhibitors are more sensitive to usually.
Fine. So you'll find out the long form. What is the drug of choice or preferred drug for PACC mutation?
So second
Akhade.
generation, sir, they act well on this, but they have a lot of toxicity. So afatinib, dacomatinib, they are useful for this, but osimertinib is also, I mean, can be used for this. But
Anything
preferred
else?
drug is
Any other
second
newer?
generation.
Any other newer combination?
Amivantamab plus lazertinib.
And okay, amivantamab lazertinib also there is some data. So you need to
Yes.
find out what is the long form of PACC mutation. Move to the next. So you're sitting in government cancer center and your patient brings you to this. You can see the photo.
No, yes.
So what you will do? And patient has a metastatic NSCLC with EGFR mutation. What will you do next?
We'll see what kind of EGFR mutation is that, sir.
Patient has exon 19 mutation.
Exon 19 deletion, sir. We will look at the sites of disease and see
He is eligible. He is eligible for osimertinib.
I mean, sir, whether he's eligible for osimertinib plus chemotherapy or not, that is what we will see.
He is eligible only for osimertinib.
Okay.
You see the company. Here.
Everest.
The Dr. Saphalta is coming in between. Coach is not allowed to speak in between.
I mean, it's
We
not
will
our.
explain it's not an original brand, so we will explain that we cannot give an assurance that it will give the proper benefit.
My question in the exam is going to be very straightforward. Are you going to use this in your patient? Yes or no?
So if the patient is not affording, if he's only affording for this, then we will use. Sir.
So you will use something which is not approved by DCJ and commit a crime. And your registration will be cancelled. And you will have to again give the exam. I'm asking you.
No, sir, we will explain this to the
Raghuram, what will
patient.
you do? अरे पेशेंट को कुछ नहीं जाने वाला ना, डिग्री तो तुम्हारी जाएगी.
Sir, I will offer the patient.
So, see, such questions are asked in exam to judge your thinking capacity and ability to take decisions, which has to be medically legally correct in the exam. What you do in outside is a different story, but in the exam it has to be medically legally correct. So, what is the answer?
So we will not suggest this drug then, because it has not been studied, sir, or not approved for that
Are you
matter.
sure? So you will let the patient die. That is what examiner is going to say. You have no empathy. Patient is dying in front of you and you will not use the drug.
We will offer a second generation TKI if they can afford for that, or else cytotoxic chemotherapy only.
Second generation TKI? Why not first generation TKI? Erlotinib, Jeptinib is that bad?
No. We can offer PEM-carbo plus Jeftinib also.
So basically, in exam, you're supposed to tell that, of course, you cannot offer this patient this particular drug. You will offer him the other options which are within his financial budget. And if you still insist, you will ask him to take opinion from other oncologists. That's the simplest answer.
Okay, sir.
Okay. So do you know any anti-HER3 drug? HER2 both okay. HER3.
Deruxtecan.
What is the cutoff for HER3 level? Just a HER2 का cutoff है, HER3 का क्या cutoff है?
Not.
What not? You don't know, or there is no cutoff?
I don't know.
I don't know, sir.
How HER3 is tested? How do not tested on the?
Not test. I'm not sure.
IHC.
करते हैं HER3 का IHC होता है TMC Calcutta they do HER3 का IHC.
I haven't seen, sir.
So my question is, before giving the anti-HER3 drug, is it necessary to test for HER3 or not? And what is the cancer in which it is approved?
Non-small
Breast
cell.
cancer.
Lung
cancer.
Lung cancer.
NSCLC.
Which line?
Post.
No, there are only two lines. Na? First line, second line, third line, fourth line. Which line?
Third line, sir.
Third line में. Second line में नहीं है. मतलब ऐसे ही तुक्के मारेंगे. तो ये देने के पहले HER3 का टेस्टिंग करोगे नहीं करोगे? What does the trial say? Akhil had shown this. Okay, find out. Next, move on. Chalo, this is my favorite question. You are consulted in big corporate hospital. See, half the time I'm making you in government hospital, half the time I'm making you in corporate hospital. So now you're in corporate hospital. One patient comes with an NGS report. He says, doctor, you are the precision oncologist I have heard of, and I come all the way to see you only. And it shows MET overexpression, nothing else. Which drug will you use? Patient in the past issue.
Tepotinib.
Tepotinib can be used in MET overexpression.
MET skipping mutation, MET exon 14
Why लिखा
skipping
क्या है फिर? What is written here?
mutation.
Which MET inhibitor can be used in MET overexpression, or there is no MET inhibitor that can be used in MET overexpression?
There is no MET inhibitor that is approved for MET overexpression, sir. Not sure if there is data.
Oh, this is not approved can be still discussed, but no data can matter. There is data for everything in oncology.
No, sir. I am not sure about the data.
You're not sure about the data. You are okay. So, what about MET amplification? What is the difference between overexpression and amplification?
Overexpression is seen on IHC. Amplification is detected by fish.
Fish.
Okay, so suppose MET is amplified. So can you use any MET inhibitor?
Again, not approved, sir.
Well, not approved वाला तो simple सा चीज है, obviously. भाई वो he has come to you. You are a precision oncologist. Most of the precision oncologists give drugs that are not approved. So forget that.
So sir,
that is why you are a precision oncologist. So you have to tell him that this is not approved. Fine. Patient says, okay, fine. I don't care whether it's approved or not approved. Give me a drug that works.
So for MET amplification with I think
so which drug? So my
we
question, I will make it simple. Which drugs are for MET amplification? Which drugs are for MET overexpression? MET skipping mutation, everybody knows.
Yes, sir.
So other two का क्या है? So you'll be very disappointed ना? मैं NGS का रिपोर्ट लेके आया, इतना बड़ा अमीर आदमी तुम्हारे पास आ गया है और देने के लिए दवाई नहीं है.
We give for MET amplification, not for overexpression. I think with copy number.
So patient is MET overexpression. So there is no drug for MET overexpression. Okay, you'll find out the drugs which acts on amplification, MET overexpression. Okay. So now you have become KOL. You have become key opinion leader. And a pharma company comes to you saying that, sir, we want to get a China-based IO to India. You have to tell me which is the best IO from China, which is the best IO. Do you know any IOs from China-based? Or your IO list ends at Pembro? Toripalimab. Any other?
Sintilimab.
Toripalimab, everybody. Is it? So suppose somebody tells you, sir, we want your advice. We want to get that IO from China to India. Which is the best China-based IO? Which is the maximum approvals in China? for maximum tumors. No, this is what we want to get. Toripalimab is for approved in China for which cancer?
Nasopharyngeal carcinoma.
Esophagus. And
Nasopharyngeal carcinoma.
Is it approved for esophagus? And
For nasopharyngeal carcinoma.
TNBC, metastatic TNBC.
oh, no, yes. So toripalimab is approved for metastatic TNBC in China?
For lung, it is approved, I think, and for nasopharyngeal, I'm
For
not
lung,
sure
it is
about
approved. Lung is approved for which particular subclass or for everybody?
that. I'm not sure. Sir.
Okay, I assume you're writing the questions. This is my favorite question. Do you know what is Cocoon strategy of giving the drug?
No, sir.
नाम सुना है? Cocoon strategy.
No. No, sir.
ट्रायल आ गया है, इसका ट्रायल का डाटा है कि ककून स्ट्रेटेजी से ड्रग देंगे तो उसका टॉक्सिसिटी कम होता है. I'll give another hint. What is skipper strategy? Same drug.
No.
Okay, I will write down. We have another 10 minutes. This is my favorite. Can you name this? You have to answer. Otherwise, I will not pass you. Name at least 2 anti-cancer drugs that are derived from animals. वो प्लांट वाला नहीं चाहिए. Non-veg anti-cancer drugs. वो विनक्रिस्टिन वो सब नहीं चाहिए हमें. पैक्लेटैक्सेल नहीं चाहिए. एनिमल वाला चाहिए. There was a big news around, I think 15 years back, 2008-9, when this drug was derived from animals. I think 2007-8 की बात है. And you know the name, but you don't know that it is derived from animal. Must have used it also. Okay, next question. Any cytotoxic drug that acts on oncogene fusion? You know, ALK inhibitors act on ALK fusion, NRG1 targeted drugs act on NRG fusion. The cytotoxic drug that acts on oncogene fusion, because that is derived from the animal. So it is a related question.
Okay.
Imatinib acts on BCR-ABL. So these are targeted drugs. Cytotoxic
Yes,
drugs.
sir.
Which one? The next hint. Have you heard of this FUS CHOP or EWS CHOP? Now you can guess the drug here. This is another favorite question. You have heard doxorubicin, epirubicin, so similar drugs, or camptothecin, irinotecan, similar drugs. So in the recently, which is such drug, cytotoxic drug, which is derived from another cytotoxic drug, and both are approved in 2 different cancers. Solid tumors. This all started from this first question, because the first drug is derived from animals. These are questions related to that.
Trabectedin and lupinectedin.
At least you could answer the last one. Trabectedin and lupinectedin. So that is a good one. I'll give that to you. So any other, which animal trabectedin is derived from?
I am
have to
not.
go back.
I don't.
कहाँ मिलता है वो? The animal which stays on Himalaya पर्वत or animal which stays in jungle, कहाँ के animal पकड़ा है?
Sea maybe,
कहाँ
sir,
में?
I think.
Sea में?
Ocean.
I am not
Ocean
sure.
में?
I am
Ocean
not
वाला
sure. I
animal.
think so. I'm not sure.
Any other drug which is derived from animal? One is Yondelis. Other is? Yondelis acts on this FUS CHOP. Yes, a fusions concept cancer में दिखते हैं. This seen on which cancer?
Sarcoma, Ewing sarcoma.
कौन सा सार्कोमा? मतलब एक ही सार्कोमा
ये
का
Ewing
मतलब ईविंग
sarcoma.
सार्कोमा?
Yes,
ये उसी की
Ewing
बात करेंगे
sarcoma.
हम। ईविंग में दिखते
हाँ
क्या ये? ईडब्ल्यूएस है इसलिए ईविंग है।
हाँ, first sorry WS.
ईविंग में दिखते हैं। तो ईविंग सार्कोमा के लिए यॉन्डेलिस यूज होता है काटता में।
But job तो नहीं पता, नहीं I'm not sure.
ओके, एनी अदर ड्रग derived फ्रॉम एनिमल? यॉन्डेलिस एक तो आ गया अभी नीचे से ऊपर, तो दूसरा कौन सा है? ओके, वी विल फाइंड आउट। वी हैव ओके, सो have you used any SERD?
Selective estrogen receptor downregulator, selective receptor modulator, selective
Yes or no? Is
androgen.
that I'm not asking you.
Yes.
My question is, have you used any SERD?
Yes,
Have
sir.
you used any
Fulvestrant.
SERD?
Fulvestrant.
Oh, fantastic. Fantastic. Good. Good. So now the better question is, have you used any oral SERD?
No.
Fulvestrant is also SERD. That's important. Good. Okay. What is SARD and SAR?
Selective androgen receptor downregulator.
Excuse me.
Yes, yes. So these are also the terms which are associated with SERD and SERMs. So SARD have selective androgen receptor degrader and SARM have selected androgen receptor modulator. What is Protax?
Protax is, sir, the new SERD which is there, which his name is Vedegestrant or something, sir. It is basically
What is it? How it acts? What is Protax?
links estrogen.
You have told me
links estrogen receptor with a ubiquitin.
You have told me
So it links.
You have told me the long form of ACRD, ACRM. So what is Protect? Is there a long form? There is no long form.
There is a proteolysis chimera something.
Dr. Raghuram?
It is proteolysis and chimera, but I am not sure of the middle.
Proteolysis and chimera में से काफी सारे अल्फाबेट तो आ रहे हैं, लेकिन काफी सारे मिसिंग भी है. Okay, so we will find out that. This is Akhil's question. Akhil has given this question to me. What is cancer cachexia? FDA approved drugs for cancer cachexia?
None, sir. So, sir, I told this. No drug is approved for cancer cachexia.
None?
Yes, sir.
None. What about this?
So it's a phase 2 data. I mean, it needs to be.
FDA का approval मिला है कि नहीं मिला है?
नहीं.
Sure.
I'm not sure if there is a.
अरे अखिल ने डिस्कस किया था ना, अखिल ने डिस्कस किया ये ड्रग.
Not yet FDA.
उसमें क्या कहा था? Okay, so you'll read about it. What is the ADC approved for CS cervix? ये भी अखिल का क्वेश्चन है, इसको थोड़ा सा मॉडिफाई किया.
ये
CS cervix में which ADC is approved? Which one?
Tisotumab vedotin.
And what is the peculiar toxicity?
Ocular toxicity causing keratopathy.
And there's one more.
Peripheral neuropathy, sir.
Bleeding events and peripheral neuropathy.
So bleeding कहाँ से होता है? अब CS cervix में जो नीचे से पर वजन bleeding हो ही रहा है, और कहाँ से होगा? आपके नीचे क्या है?
Epistaxis.
Epistaxis होता है. Good. So post generation ALK inhibitor का किसी को नाम मालूम है? Last year WLCC.
Sir, it also starts some T.
Do you remember the photos of the cats that are beginning?
Sir?
How the cats look like in the exam? I've shown you the photo. Now your face is looking like that.
Sir, Tralectinib or something. I forgot.
Okay, वो छोड़ो, नाम छोड़ो. What is the advantage of fourth generation ALK inhibitor?
Sir, I mean, good efficacy and good intracranial efficacy with less neurological side effects as compared to lorlatinib.
Yeah. Do you know any one specific alkyl inhibitor where step-up dosing is required?
Brigatinib,
That
sir.
means
Brigatinib
brigatinib.
because of early pulmonary events.
Yes, good. Evita criteria is a simple question here.
Evita is, sir, enfortumab vedotin ineligibility criteria. So basically, anyone. So there are 5 points, I think, sir. Out of which, if there are 2 or more, then the patient is EV ineligible. Performance status of 2 or more. Creatinine clearance of some less than 30, I think.
What is the most important?
Peripheral neuropathy, ophthalmic toxicity, and
something which you measure in blood test. HB1AC?
HB1C of more than 8. Yes.
Okay.
Hyperglycemia.
So now very soon the modified Evita will come.
Okay.
Any other drug that you know for which has similar criteria, named criteria, for it?
For cisplatin we use that.
वो cisplatin eligibility ineligibility criteria किसके नाम से है?
Forgot the name.
मैं hint देता हूँ, इंडियन के नाम से है. Okay, I will give you another hint. गुप्ता criteria सुना है?
Sir?
गुप्ता criteria.
नहीं sir.
कौन से गुप्ता की बात हो रही है?
Sudeep? I'm not sure.
अरे सर के नाम पे criteria आ जाएंगे, don't worry. But sir, it's not in bladder cancer, ना?
Yes sir.
Okay, we'll find out.
Okay.
तो zolbetuximab का mechanism action क्या है?
Claudin 18.2 के against it's a.
Wait. ये Claudin 18.2 में 18.2 क्या होता है? 18 is a gene का नंबर है या 18 कहाँ से आ गया मतलब? हाँ वो भी 0.2.
क्रोमोसोम नंबर 18
and DNP level. हाँ
Yes,
क्रोमोसोम नंबर 18 ऐसा मस्त चिपका देने का क्रोमोसोम नंबर 18 और 18.2 क्या हो गया मतलब? At the DM and DNP level, you need to go into the depth. Whenever you see something, you have to find out why that particular name has come. How many claudins are there? Okay, you'll find out. Yes. What is the peculiar side effect? What is the peculiar side of zolbetuximab?
Vomiting, sir.
One. Now the question is why vomiting occurs in zolbetuximab? Why it is so immediately?
I'm not sure. Sir. Claudin must be there in the vomiting pathway somewhere.
So कहाँ पे है claudin? So we'll find out.
Yes.
What is the biomarker cutoff? कितना claudin चाहिए?
75% बोला सर.
75%.
75%. Correct. Yeah, that you will find out. Now we have, I think, 4 minutes left. You can find out what is the difference between sacubitril vedotin and sacubitril triamcinolone. Good, yeah. Fantastic. You are pass. So, zanidatamab का mechanism of action क्या है?
Biparatopic bispecific antibody.
Biparatopic. This is, I think, second last question. Can you pronounce this drug name?
I can try. I don't know.
What?
Noga.
अरे नाम पढ़ना है रे, नाम ही पढ़ना है.
Noga pendikin alpha inbac PMLN.
What is the mechanism of action? वो तो लिखा है BC जर्नल फॉर नॉन मतलब इनोवेटिव ब्लड कैंसर में FDA ने अप्रूव किया है. That is last year. Mechanism of action क्या है? नागा पेंटिडिन अल्फा. आगे का मुझे पढ़ने को नहीं आता है.
Interleukin must be some.
कौन सा interleukin?
2. I mean, I'm not sure.
You will find out. Agonist है, antagonist है? You will find out.
Yes.
This is the last question, I guess. Yes. Do you know any anti-cancer gun which is given as aerosolized? Means we want Pembro to come in water, but Pembro abhi tak water mein nahi de rahe, but aerosolized में कौन सा drug देते? You have seen that being done?
No, sir.
Pakka. If I tell you the name, then you will say yes, 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 yes. Hypic का नाम सुना है? What is the other
yes.
thing? What is the other thing? What is
Nypec,
the let?
Nypec.
What is?
Nypec,
One is
sir. Normothermic. Hyperthermic and normothermic.
No,
Intraperitoneal.
what is the other one? Hypic and what is the latest thing that oncosurgeons keep doing?
Pipec.
So Pipec में क्या होता है? What happens in Pipec? How
Pressurized
the drug
dose
is given? How the
pressurized
drug
dose
is given? So which drug is given in Pipec in aerosolized form and how they make it aerosolized? Find out. So that was the last slide. So thank you. As I told you, this entire exercise was to make you stimulate that you will learn and read and keep doing that because learning never ends. And yeah, you can follow me next if you want to. And please get yourself organized. Whenever you get new information, just don't try to memorize things. Try to find out, go beyond that. Because ultimately in DN and DNP level, you need to know those things. And over the years, it just keep on getting accumulated. So probably if you develop the habit now, you will not get bored after 5 years, 6 years. It is not required of passing the exams. You will pass the exams. And it's probably not required for doing routine medical oncology practice because that is also not that difficult. It is for your own satisfaction, your own love of the subject or passion of the subject that you should keep learning. So I think we are finishing in time, 4 o'clock. Thank you.
Thank you, sir.
Thank you,
Thank
Dr.
you, sir.
Amol. I'm sure for Yash and Raghu, it was the longest 1 hour in their whole life. Don't worry, these questions will not be asked in the exam.
Yes, they will never be asked.
What you're examining. So thank you, Dr. Amol. It was extensive.
Thank you.
In every slide, you can find out, you can spend almost half an hour to find out what actually it is. And it was a great learning opportunity. Thank you all.
Thank you. Thank you. See you.
Well, thank
Take
you
care.
so much.
Bye.
Thank you so much, Amol sir, for joining us. And thank you, Saphalta ma'am, for doing the moderation. And I'll especially thank Dr. Akhil for taking out time and making those slides in his busy schedule. And I would also request all of you to, follow a few accounts on Twitter so that all these updates are, seen every day because it's very difficult to accumulate all these updates and, mug it up. So a few accounts, I'll just put it up on the chat. And with that, I will want you to come to our next session, which is drugs in plasma cell neoplasms. That is going to be on 27th of April. And we have a very nice startup with Dr. Pankaj Malhotra from PGI Chandigarh, who's also heading the Indian myeloma group. We have Dr. Udayan Mandra sir, who's from AFMC, and he's our moderator. Our mentor is Dr. Hamza Dalal from Mumbai, and our speaker is the very talented Dr. Nihanti. So again, I would like to request you guys to join us next week, this very same time, for a new Gurukul series. Thank you. And I am adding 3 accounts for you to follow on the chat box. Please do. There is Dr. Akhil and Dr. Amol Akhade, sir. Thank you. Bye-bye.